Hello, everyone. Welcome. We are so happy to have you here with us. My name is Priscila Giamassi, and I will be the host for your today's session. We are honored to present you this four-part learning series as a collaboration between the Central East ATTC, Central East PTTC, the National American Indian and Alaska Native PTTC, the National Hispanic and Latino PTTC. The series is titled, What LGBTQIA2S BIPOC Want Prevention Professionals to Know. And this is our third session. We will discuss how can we improve the current behavioral This session is titled, Moving the Needle, How to Improve the Current Behavioral Health System to Increase Engagement and Retention of LGBTQ BIPOC. Next. Here is a disclaimer with information about the fundings of our TTTCs. Next. Please allow us to share some brief instructions about today's virtual learning session. A copy of today's presentation will be also made available after today's event. The lines will be muted throughout all the presentation, so to minimize background noise. We will get to the Q&A portion of our session, and you will have the opportunity to ask questions by clicking the Q&A box, and the moderator will present your questions to the panelists. We will be asking you to fill out a brief survey at the end of this event. The satisfaction evaluation is very important for the work that we do and provide us with the opportunity to improve our training efforts. Although we are not securing continuing education credits for this event, we plan to do for future events. A certificate of completion will be sent after today's session. So let's begin. Here is the ATTC network map. The ATTC is a multidisciplinary resource for professionals in the addictions treatment and recovery services field, and it was established in 1993 by the Substance Abuse and Mental Health Services Administration. Next. And here's the map of the PTTC network. The PTTC is a multidisciplinary resource for professionals in the prevention field, and it was established in 2018 by the Substance Abuse and Mental Health Services Administration, SAMHSA. The ATTC and the PTTC network serves the 50 states, the District of Columbia, Puerto Rico, the US Virgin Islands, the Pacific Islands of Guam, America Samoa, Palau, the Marshall Islands, Micronesia, and the Mariana Islands. Next. You will receive a copy of these slides, and you will be able to click on each logo to learn more about each center and check the resources that are available. We will also provide the links on the chat. Now it's time to introduce our moderator. Jay Yarbrough is the ATTC Training and Technical Assistance Coordinator with years of experience in public and population health. Jay, could you please introduce our amazing panelists?
Yes, I can. Thank you for that, Priscilla. I'm super excited to be here with you all. I'm just going to introduce our panelists for today. Next slide. We're going to start with Miss Anna Mabel Jones. Anna Mabel Jones is an Oxford House Resource Coordinator in DC and Maryland, a nonprofit network of 3,336 international self-help recovery homes. Next. To Miss Dimitri Garner. Dimitri is a peer recovery specialist at the Emergency Department, and this has given him the vantage point to encounter minority disparities. Our next slide. And Dr. Matt Ignacio. Dr. Matt Ignacio is currently an assistant professor at Arizona State University's School of Social Work located in the Watts College of Public Service and Community Solutions. Next. And last but not least, Humberto Orozco. Humberto is the board chair of the Latino Link, a local nonprofit organization that advances LGBTQ equity for the Latinx LGBTQ community in Metro Atlanta. Next slide, please. And once again, I'm going to welcome everyone to session 3 of this 4-part virtual learning series. Next slide. So we're gonna get started from this, just introducing our panelists and getting a bit of information and background on them. So I'm gonna start with Ms. Anna Nicole Jones and then go down the list and ask a few questions for you, Ms. Jones. First, can you tell us a bit about yourself? And in that description, how do you identify, where are you from, and what is your role, and what does that role do? Ms. Jones?
Hello, and thank you, Mr. Yarabo, for that awesome introduction. So my name is Anna Mabel Jones, and I'm a woman in long-term recovery. And what that means for me is I haven't used a drink or a drug since August 30th, 1999. And surprisingly, that is my birthday also. So it's 2 anniversaries when that happens for me. And I'm looking forward to celebrating 22 years on the 30th. I identify as an African-American woman in the BIPOC community. My pronouns are she and her. Also, where I'm from. So I'm originally from Washington, D.C., born and raised, but now I live in Laurel, Maryland with my husband of 15 years. We were able, through the process of recovery, to buy a home. So I'm a Maryland, I live in Maryland now. And what I do, I'm honored to be a resource coordinator for Oxford House, Inc. And Oxford House is a network of recovery housing. We started in 1975. And as you read, we are now over, 3,000 houses worldwide. What I do, I'm a resource coordinator. So I get to connect to people on their wellness on a one-to-one basis. And it's been an honor to do that in recovery and help people and guide them in their pathway to recovery. So I'm so honored to be here. Thank you.
Thank you, Ms. Jones. I appreciate that. Dr. Nacio, you are up next. Same questions. How to identify, where are you from? What is your role? What does that role do?
Thank you. Good morning, everybody. Good morning. My name is Matt Nacio. I'm a tribal member of the Tohono Nation, which is our ancestral homelands are located in what is now southern Arizona and northern New Mexico. Well, as far as our traditional homelands are concerned, I'm currently actually on our homelands here in Tucson, Arizona. I am faculty at our Phoenix campus, but I will be teaching at our Tucson School Social Campus this fall. I guess who I am is somebody that has advocated for the health and justice of those who are marginalized within our healthcare system, whether that be because you are American Indian Alaska Native, whether that be because you are LGBTQ Two-Spirit, whether that be because you're HIV positive, whether that be because you grew up in a poor, you come from a poor family or a poverty background, whatever the case may be, my argument has always been that folks should not be denied access to care based on their identities. And so that is a through line in my research currently. And with over 21 years of experience, addressing HIV in and among Native communities. Thank you. I'll work on.
Dr. Nacio, I believe you are muted. Can you unmute yourself?
Yeah, I was done. I'm just changing out my mic.
All right, we're going to move on to Mr. Garner. Mr. Garner, same questions. How do you identify? Where are you from? What is your role, and what do you do? What does that role do?
Thank you, sir. Thank you, Mr. J. I want to thank the panel for being honored to be on this panel, and actually being a male that has been in active addiction for 26 years. My identity is he and him, but I get the privilege to be of service, and that's part of my identity. I actually currently reside in Baltimore City, and I serve the population of substance use disorder patients in Baltimore County for a hospital called MedStar. And our hospital, one of the hospitals part of the system, is called Franklin Square Hospital in Baltimore County. It lies on the edge of the city and the county, right there on that edge. Most of the populations that we do serve is poor individuals that qualify for Medicaid. to Medicaid recipients. The population we serve is of all walks of life, from straight, gay, and also from both genders. And what do I do at that role? Well, right now I'm the co-chair for health wellness at the hospital at Franklin Square, and also my role was in the SBIRT department, substance brief intervention department that we service the emergency room and the hospital. Thank you.
Thank you, Mr. Garner. That's super exciting. SBIRT, you know me, I love SBIRT. And last but not least, Umberto, same questions. How do you identify? Where are you from? What is your role? And what does your role do? Umberto, if you can speak a little bit louder, I think your volume is cut out. Still having some audio issues? Is it just me or?
Yeah, we can hear you, Umberto.
Okay.
Jay, do you want to move to the next question and then we can come back to Umberto once he figured out his audio?
Sure, absolutely. We will just go right into the meat of it. Umberto, are you there?
Oh yeah, I can.
There we go. Now,
I think I know
yes,
what
no, it's perfect now. Let's go for it.
Apologies.
No, you're fine.
Thanks for your patience. Yes, Humberto, immigrant, cisgender, gay, Latinx guy. Where I'm from is not too complicated. I moved here when I was 8 from Mexico. I live in Atlanta. I've been here for 20 plus years. I work as a Latinx. I work at a Latinx organization serving the LGBTQ community in Atlanta, called Latino Link. And I also work as a community educator as part of Emory's School of Medicine, where I am a liaison between the Latinx community and research opportunities, clinical research.
Thank you so much, Umberto. Super excited to have both Baltimore and Atlanta represented on the panel today. So I've lived in both places. So very exciting. All right, so let's move right into the meat of the conversation. So I'm going to start this off with 3 questions. The first question is a 2-part question, so feel free to ask me to repeat the second part if you need be. We're going to start with Mr. Garner. So the question is, how have you actively worked to identify and address the gaps when working with BIPOC LGBT communities? And the second part to this question is, how have you been successful with addressing your own biases to meet the needs of these different clients?
Thank you for the question. The first part of the question, I believe that you have to notice who you actually serve. So be mindful of the population that you serve, and even with, especially in the role that I have dealing with recipients of Medicaid, you have sub-ethnic groups within that community also. It's just not just one facet of individuals that you face. So please be mindful of who you actually serve. The second part is that you have to have cultural etiquette to understand how to identify and address any kind of gaps. Have cultural etiquette within the population that you serve, meaning that if you need more training, please get more training. If you need to shadow somebody else that is more familiar with working with that population, then do so. With each individual interaction, it only can go forward if you can make that connection. And so that connection has to be made with understanding cultural differences. Understand cultural differences, understand your limitations, and use all the resources that are available to you in that organization. The second part of the question, how have you been successful? I would like to think I am successful in every engagement, but the reality is I am not. And so the only way to engage, if I have an intervention that I felt as though that I missed the mark, or that somehow it didn't go the way that I thought it was going to go, I have to engage with other members. I have to actually do a rundown after, or what we call like a decompress of what happened. So I have to be honest, go to my peers, and say, hey, I think I missed the ball here. Can you help me? Maybe I need some more understanding. And I think that it's successful. Always not be critical of yourself, but have other people that can hold you accountable. So be honest about what happened in the rooms. Be honest about where you felt that you fell short. And from there, move on and grow. Thank you.
Jay, I think you're muted.
I knew that would happen at least once today. I promise. I knew it was going to happen. My apologies. We have some time left in your slide, and I just want to maybe dig deeper or further explain what you mean by cultural etiquette, if you feel free.
Yeah, cultural etiquette. So, for instance, if I have someone that comes in of Latin descent, then I first ask them about, do you speak English? Okay. Now, be mindful of this, that a lot of times that when you ask or how you ask somebody a question can get a response that you don't like. And from there, the conversation goes nowhere. So for me, having a point of view of, do you speak English? I'm actually looking down on that person, because I figure as though if you don't speak English, then you're a second-class citizen. I have to get on the same level. When I talk about cultural etiquette, my approach has to be inviting. I cannot talk down to you. I cannot belittle you. I cannot treat you as a second-class citizen and thinking that you're going to be engaging with me. So it's your approach. Cultural etiquette is about your approach engaging with the culture that your population that you serve.
Thank you for that. I really appreciate that. Ms. Jones, I'm going to ask you the same question. How have you actively worked to identify and address the gaps when working with BIPOC communities? And the second part is, how have you been successful with addressing your own biases to meet the needs of different clients?
Thank you. And thank you, Dimitri. That was so powerful and just a great way to connect, with the culture. So for me, if you don't know, ask, right? So don't just assume. And I never do that. I don't assume. I'm okay with asking today because I want to show up and help that person to the best of my ability, right? And I'm going to combine both of my questions with one, because I feel like we all have biases. Sometimes we just don't know, right? So don't try to make it like you don't have bias, because just about everybody has biases, right? So it's in knowing those. And if you're truly being a person that's working in this field and you want to help, then you'll learn more about culture and cultural competence, right? So that you can meet that person where they are. Dimitri tapped on it, like, don't think you're up here and that person's down there, meet them at that certain level to treat them as a resource so that you can really help that person. We're in a field where we want to help people. We want them to grow. And in today's time, we have to know times change, people change, right? And I love the part about if you don't know, go to a coworker or ask them. Don't feel like you have to do it alone. Because you're hurting the person more when you're trying to act like you know everything and you don't, right? So for me, it is totally being okay with asking, being aware of your biases, knowing that everybody wasn't raised like you, everybody's culture is not like yours, treating that person with respect. As an African-American woman, I've just been through a lot. For me, as soon as Dimitri was talking, I went into like, oh my God, microaggressions. Because I get that all the time. And I'm like, okay, really? But now I've learned to speak up as an African-American woman when people come to me with microaggressions and things of that nature. And I want the people that I'm working with, even in the field of recovery housing, to have a voice, right? And feel that when I come, they can say things to me and we can have a conversation. And if I don't understand something, or if I have a bias on it, I need to check myself and say, hey, what's really going on, right? And seeing, can I show up with that bias, or if I can't? Because if I can't, then I need to have that person, again, like Dimitri said, work with someone else. So it's being aware of that and not thinking that your way is the only way, because it's not. Thank you.
Thank you, Ms. Jones. And if you will allow me to your statement, there's so much follow up happening here. You have a bit of time left. When you ask, if you don't know, ask. I know for myself as being an Afro queer Latinx individual, how do you ask? In which way? What is the language needed to come?
Thank you. That is just, yeah. Thank you. I feel it's showing up with empathy and compassion, and really listening to try to hear, which way you can help that person. And I think in that showing up with empathy, you'll really know what to ask, because they'll tell you if you're truly listening, and listening with compassion. You'll know what to ask. Or you can even, don't be afraid to say, I don't know. I need some help. Yeah. Thank
you, Ms. Jones. That was lovely. We had a question in the chat I'm going to send back to Mr. Garner. It comes from Robin. And she asked, so instead of asking, do you speak English, could the question be, what language are you most comfortable using?
Robin, most definitely. In the day and culture that we live in, I wouldn't consider that being politically correct as being so kind of out of tune with people. People use the term politically correct as if it was negative. But actually, as Anna put it, is actually a positive. Is actually becoming engaging, knowing, having cultural empathy for the individual that you're serving. What language are you most comfortable using? Absolutely, Robin, because it gives them a chance to talk to me now. It actually gives them the chance to become engaging with me. If I'm meeting you halfway, they're meeting me the other halfway by telling me what they're comfortable with, telling me how they communicate. And so going forward, now we're at an even playing plane. I know where you're comfortable at. I know how to go and engage going forward with you. I would not ask you, do you speak English, and expect to have a response of no, I don't, or yes, I do. And it'll be something that is going to be in a positive light. The outcome's going to be in a positive light, because it's not. Because now I'm like everybody else that have come to that person, looking down on them, having them look as if they're a second-class citizen. And as second-class citizens, a population of people that are in the environment of seeking help, they're always feeling as though that the help is never going to be provided. So right now I'm starting off as another barrier instead of being a resource. How do I come into the room as a resource? It is not starting off as a barrier. Be engaging. Cultural differences, you have to understand they do exist and go from there. But it's what you say next that's going to be the engagement process of successful, or another person that is going to be seeking somebody else, hopefully down the road, but you could be that person. Thank you.
Thank you for that, Mr. Garner. And I also want to encourage folks to put their questions in the chat if you have some as we go on. Okay. We're moving on to Umberto. Same question. How have you actively worked to identify and address the gaps when working with BIPOC LGBT communities? And how have you been successful with addressing your own biases to meet the needs of different clients? And before you answer, Umberto, I also want to know if there's any confusion around BIPOC and LGBTQ, please put it in the chat. We can explain what that acronym means.
Okay. Yeah, thanks, Jay. I have been working in this nonprofit sector with Latino Link, which is a nonprofit organization serving the Latinx LGBTQ community for about 5 years. I've been part of the organization for the last 4 years, and that is part of the mission, is to address those gaps that folks in my community are having challenges accessing, and A lot of the work that was done early on was my predecessors doing outreach and doing a needs assessment. But since I've been part of the organization, I have been doing my own. I mean, not only me, but like a team of volunteers, which is an all volunteer organization. Just trying to reach community and get their take on what is needed. So just making sure that you talk to people and not make assumptions. Like my colleagues have said, you have to get community buy-in and engagement for you to serve their needs. You can't identify those needs on your own. So being humble and open to having conversations has been one of the strategies to identify those needs that the community has seen. And here in Atlanta, we've noticed that, or from the beginning, Latino Link was trying to address the equity gap in accessing healthcare and also accessing legal assistance providers. That's something that we're constantly working to address because it's not something that has been fixed, and I don't see that. I mean, we've seen some progress, but it's still an uphill battle to get equity in that arena. But like my colleagues here, I'm working on addressing my own biases. I still I recognize that I have biases like all of us, and as someone living with HIV, I sometimes cringe when I catch myself using stigmatizing language, not using people first language, though I try and do that all the time. It's like sometimes it slips, and it's those instances that reminds me that I need to continue to address my own biases, and there's a lot of work to do, not only internally, but as a community to address those things that I think hold us back from really growing as a community and moving on and being more open and just on the right track to get equity for everyone in the Latinx community.
Thank you for that, Roberto. I want to point out that someone placed in the chat a conference that's happening in September. If you're following the chat, it's the National Latino Behavioral Health Virtual Conference, Envisioning Latino Behavioral Health Equity in the Next Decade. I didn't know about that until just now, so I'm very excited, and I'm going to sign up for it, so I encourage everyone else to. And last but not least, Dr. Ignacio, same sort of questions. How have you actively worked to identify and address the gaps when working with BIPOC LGBTQ communities? And how have you been successful with addressing your own biases to meet the needs of these different clients?
Yeah, one way I've actively worked to address the needs is to ensure that there is a systematic way community's voice is in policy, it's written in policy, or somehow it's codified in the organizational structure or institutional structure, that community has a real voice and plays a part in the shaping and direction of programming. And for this particular issue around LGBTQ Two-Spirit clients, ensuring that they have a real voice in the creation of the programs that are designed to serve them. That's easier said than done. That can hinge on years of relationship building activities both in person and virtual. So that engagement piece that everyone is talking about, you know, it can take time. And so as a provider, to be patient. I know that's again, easier said than done, but it is a process. And then as far as addressing your own biases, I guess cultivating a practice where you don't run away from them, right? And that's a starting point, that there's no reason to run away from your biases, that as everyone has said, we all have them, and that will only make you that much more of an excellent provider by being open to and exploring those biases.
Thank you, Dr. Ignacio. We have some time left in this section, so I want to come back to two things that Umberto and Dr. Ignacio said, I think kind of tie in. And one was community buy-in from Umberto, and Ignacio mentioned community voice in programming. And I just wonder what that looks like, and how do we get the buy-in from communities who are just being defensive and trying to survive against systems that haven't worked for them, and how does that play out?
I think I'll just take a stab at that. Recognizing my own privilege and positionality, that yeah, I have dark skin, yes, I'm Native, but that doesn't mean I can just walk into any Native community and I have access to it. So going back to earlier what Dimitri was saying, and I really like that response about being very welcoming. It is a physical act of engaging people by the way you hold your body, by the way you hold your breath, by the intent you have in your heart. I mean, all of those are critical elements to doing effective engagement with communities that you're not familiar with.
Yeah, I would add to that and say, yes, you have to build those relationships with community and maintain them. You can't expect to show up without making any effort to engage with them and expect to be welcomed just because you look like them. And yes, privilege, you have to recognize that. You show up and you need to be humble about that and show that you care and that you're not just using community to make advancements, like personal or whatnot. It could be an organizational thing too. In research, I've seen it too, where I've heard people are not open to doing buy-in, or there's no community buy-in because there hasn't been a relationship with the researchers that are trying to gain access to communities. So there's a long road ahead in trying to get communities to be more open, because it takes time to cultivate those relationships.
Thank you both for that. I appreciate that insight. I'm going to keep this going to a different question. This will be a three-part question. And again, feel free to ask me to repeat this. I'm going to start with Umberto. What barrier as a professional do you face when trying to increase engagement? Also, what barriers have you overcome? And in which ways can the community be involved in these barriers to increase engagement? Umberto, you want to start us off?
Yeah, unmute first. Yes, thanks for that. I've noticed the barriers to engagement be parallel when it comes to getting people to participate in programming offered by the nonprofit that I'm involved with, Latino Link, and also in the work that I do with Emory School of Medicine, there's just one of the barriers is just not enough information that is culturally relevant for people to access those services, or whatever it is that I've worked on. I mean, from clinical research to HIV prevention, or even just mental health access. It's always been seen as it's not something that I want to engage in because I don't see myself in that, or I don't have enough information to make a decision on getting involved. So it's just been mostly those challenges where people are not ready to even have a conversation because they don't feel empowered to get just engaged to do things like get an HIV test or participate in COVID research. One of the most recent studies that I've been working has been doing community outreach or just community COVID testing, and the amount of people that decline using or getting tested has been unsurprising, but also I understand where they're coming from. There's a lot of misinformation out there, and now people are getting complacent because the vaccines are available. So with that, I have also noticed some successes. People have reached out to me specifically and asked more information about COVID because they see me as someone that is trustworthy. And so I think it also reflects the need for more folks that look like them, like Latinx, BIPOC people, so that they are more informed ultimately. I mean, if people are feeling comfortable to ask one-on-one questions, I think it reinforces my belief that there's this lack of trust based on lack of representation. So let me see did I miss the third piece to that? You wanted to know if
in which ways can the community get involved or be involved?
Right. Okay, thanks, Jay. I think the best way that we all could get involved to get more community is to become advocates for these services, be it mental health or HIV, sexual health. Just become subject matter experts and invite people in so that they can become more comfortable and engaged in the process.
Thank you, Humberto. I'm gonna, Mr. Garner, same questions. What barrier as a professional do you face when trying to increase engagement? What barriers have you already overcome? And in which ways can the community be involved in overcoming barriers to engagement?
I know, Jay, they would have me to be unmuted response here. Starting with the first question, what barriers as a professional do you face to increase engagement? I think Humberto hit a point when he's talking about being clients that are not vaccinated or being or have some fear of COVID-19 and its variants. But that is a mixture of mental health and with substance use disorders. The strain of the last 16 plus months of dealing with COVID and the population that I serve has shown to be problematic. To try to differentiate between, is this a mental health problem on top of a substance use disorder, is above my scope. But at the same time, I have to be the one that's going to advocate for that individual to seek some kind of other services. So that's a barrier right there, trying to separate the effects of COVID-19, mental health stress, mental illness, and substance use disorders. To try to be the one, I'm the resource. I have to point you or suggest the point of line for you. And it's hard to do with all these extra stressors. So with that being said, as a professional, I have to be more engaging in my own education. The education of knowing where to point someone in the right direction when I am not sure of how to complete a kind of engagement with that person or individual. The second part of the question, what barriers have I overcome, is actually providing resources for trauma, providing resources for mental health. As part of the expert department at my hospital, I fall under behavioral health services. But at the same time, working in that organization, people are screened for substance abuse. And so they go directly to the expert department. And what happens is the individual or patient becomes an expert patient. But that is not always the case. The case may involve other barriers for that individual. They may have trauma issues. They may have mental health issues where they may not be taking the medications that they're being prescribed before in the past. They may have failed to meet doctor's appointment for mental health and physical health. So it's a lot of barriers that become involved in just providing a service for substance use disorders. I would promote to any professional that is listening, do not just be one-sided when it comes to the point of view of being of service. Education is a key point of actually helping the community that you serve, but also being able to listen to know what their needs are. Because a lot of times we may think that we're being of service, but if we don't actually be in tune to what that patient is asking for or what that patient is lacking of, then we'll miss the whole mark of our service. So if you're in the field of servicing any population, not just the populations that we have on this dais of LGBTQ and BIPOC, but any population, be attentive to what the person is asking for. Be attentive to what their needs are. Be attentive to why they're actually having an intervention with you. Because at the end of the day, you are the resource. The third part, and I'll be quick, in what ways can the community get involved? I think the community has to get involved. It has to take a step back because the community is not involved a lot of times. And so the only time that a community get involved is when it comes down to individual families, when families are affected. That means that if families are affected, then we have to be that resource to get the families involved in that individual's life and in the individual's recovery. So a lot of times, especially where I actually serve at, communities look at substance use disorders and mental health with a stigma. And I'm sure that's all across the country and the world. So when we find a family that's affected, then we have to engage with that family, get that family involved, and then it'll spread from there. Because as a community, hey, we have a problem here in the LGBTQ community and the BIPOC community, they're going to look at you and say, that's not my issue, until it becomes their issue. And then it's our job to get them engaged in that issue. And then maybe we can spread the message of change of a new way of life to that community that we serve. Thank you, Jay.
Thank you, Mr. Garner. I appreciate that response. Same question from the post, Dr. Nacio. What barriers as a professional do you face to increase engagement? What barriers have you overcome? And in which ways can the community get involved?
One of the barriers, as a former national HIV trainer working with Native communities across the United States, was, in that time was stigma, was community stigma towards talking about HIV, talking about drug use as a risk factor, talking about injection drug use among Native women. I mean, those subjects were very taboo, all very important. Particularly in communities, rural and reservation communities, where maybe there isn't access to care and treatment, or where there is no visible LGBTQ two-spirit community. But when I think back to that work, there has always been, and I imagine there always will be, what we refer to as these lone champions that were out in the community who felt that maybe that HIV was an important issue, that LGBTQ issues were an important issue, that drug and alcohol abuse in community was an important issue. And perhaps they were the only person that had a real voice, or I shouldn't say real voice, but had a voice that was heard. And so part of my role as a professional social worker is to support that individual, support their effort, be a cheerleader, take random phone calls in the afternoon, when they're having maybe a great success in their day and they want to share it with somebody. Be that support for them and partner with them. And I can say, just looking back, that because of that work over time, momentum builds, more people get involved, and it's a really, it's what an honor, to be a witness, to see processes like that unfold in different communities and different tribes across the United States. And I would encourage you to consider that in your work.
Thank you, Dr. Nacio. And last but not least, Ms. Jones, same questions. What barriers as a professional do you face when increasing engagement? What barriers have you overcome? And in which ways can the community get involved?
So thank you for the question, and thank you, my colleagues, just awesome answers to that. Some of the barriers that I see as an African-American woman and as a resource coordinator, getting to work with people in our Oxford houses one-on-one. So these are people who, they're working on their recovery. They want to grow, in this process and, become productive members of society even more, because they're working on one thing to grow to another one. So some of the barriers, Dr. Ignatius touched on it, stigma is always out there, right? So that barrier is always there, not just even within the addiction, but within your race. Right, it's within your race at times. That barrier that you're dealing. So you're dealing with stigma on a lot of different levels. Not just addiction or mental health. Dealing with stigma in your culture that can be happening with that. So that is a barrier, and I think something that's helping with that is working with a person one-on-one. We don't get to do that as far as a lot, when we need to work with the person one-on-one. And I get to do that. So I was thinking as everybody was sharing, and I was thinking that recovery capital, that's the new buzzword, right? So it's like really knowing that we have to meet them where they are, and we have to work on human capital, social capital, physical capital, culture capital, right? Because those are barriers. And if we're not tapping into that with different people, then we're missing out. Right? And they can't move to another level, because we're not tapping into what needs to happen first. Sometimes we think, okay, once we get the addiction together, it's okay, but it's not, because really we need to be working on, their physical. Physical needs to happen first for them to grow on another level. So those can be some barriers if we're not meeting them where we need to meet them at first. And we're thinking that one thing needs to happen first in order for them to succeed. It's meeting them where they are. So, and then in listening to people, listening to everybody, I really felt strong, because if we as practitioners and, as preventionists, if we can't take care of ourselves, then how can we take care of somebody else? So sometimes I would say in my culture, it's always about taking care of people and we're not taking care of ourselves, right? So a lot what the community can do for me on something like that is talk about what's really, really happening and really talk about it. Don't cover it up. You know, these things are happening in the dark and we need to bring them to light. So things like community listening sessions. I'm just all for organizing and advocating and really making that person feel empowered. So, you know, in order to do that, they have to, you know, connect in the community on that level. So even with the Recovery Capital, connecting the community together on that. So, yeah, thank you.
Thank you, Ms. Jones. I appreciate that. And I'm excited for you to answer. We're gonna move on now to our next question. And that is, when has the needle been moved forward? In other words, when have you seen increased engagement and retention among BIPOC LGBTQ clients as a result of your efforts? And we're going to start with Dr. Nacio.
Great, thank you. This is the best part of the work, or one of the best aspects of the work, is when you get to see the needle move in community work. I think, I mean, I have a couple examples. I'll settle on a national example. And I mentioned this in a previous session, is that there's just more visibility around Native LGBTQ Two-Spirit individuals in the form of community-based advocacy groups. So the Montana Two-Spirit Society, the Tulsa Two-Spirit Society, the Phoenix, LA, Oakland, or Spates, Bay Area Indian Two-Spirit Society. All these community-based groups can be found on, you know, through Facebook, through social media, that connects community members together. And I just think we are at a beautiful time in that regard, because for so long it seemed like even within Native communities, even within tribal communities, talking about LGBTQ issues, you know, it came with stigma. And I think now folks certainly have become more not only embracing family members who identify as, but really kind of getting to a place of honoring our relatives who are LGBTQ Two-Spirit, and celebrating their historical pre-colonial role as healers, as caretakers, as undertakers, as medicine people, as holy people. And that shift on a national level is really encouraging.
Thank you, Dr. Nacio. I'm going to pose the same question to Mr. Garner. When has the needle been moved forward? And in other words, when have you seen increased engagement and retention among BIPOC LGBTQ clients as a result of your efforts?
I think I started to see in the organization that I work in, when this may sound funny, but when I first seen a unisex bathroom, when they stopped putting up male and female and had a bathroom for transgenders, for that community that everyone has decided we don't know what to do with when it comes down to a bathroom issue. So they decided to have a bathroom just for transgenders. And I thought that was amazing. Did the culture start to change? And you would hear some associates smirk at the bathroom, but now they start smirking. The culture has changed because they're more accepting of, this is just not their issue, it's all of our issue. Their pain is our pain. And the most thing that I seen that was this hardening at first was that the minorities that have been oppressed in this country for so many years became the oppressor for the LGBTQ community. And I just didn't understand that part. But later on, the culture started to shift in my organization. And then I started to see doctors become more engaged with different populations. The stigma of a substance use disorder wasn't of a second-class citizen, but of a patient that needs help. So I started seeing it at an organizational level. Then when it comes down to the engagement that has increased in our families' lives, in our community lives, because everybody has been affected or knows somebody's been affected with this opioid epidemic. And someone has lost somebody that we know, or someone has been affected where they have received treatment or in the process of seeking recovery. So a lot of people have been affected, so much so that the engagement is just by seeing the shift in the culture, shift in, in the minds of people in the culture, shift of it's just not your problem, but our problem. And that is the way that I can engage, that I can gauge the needle being moved, is by seeing how people respond and receive the message of a new way of life. Because a lot of times when I talk about a 12-step program or engagement in a treatment center, or just in individuals seeking mental health, somebody in that family has said, oh, by the way, yes. Oh, by the way, yes, I have known somebody that has been down that road. Or by the way, yes, I have actually sought treatment myself. So this is not a familiar issue with anybody. It's just getting everybody on board that this is a pathway that is successful, and getting everybody on board of saying that, you know what, this may actually be the difference between life and death, as seeking treatment for our mental disabilities and treatment for our substance use disorders. Thank you.
Thank you, Mr. Garner. Same question to Ms. Jones. When has the needle been moved forward? In other words, when have you seen increased engagement and retention among BIPOC LGBTQ clients as a result of your efforts?
Thank you. And thank you, Dimitri. That was, you brought back something for me to think about. So I really feel like it's turning into a movement. The needle is being moved. And as everyone was sharing, I'm like, it's being moved right now. Look at us. We're talking, you know, we're actually having a session, you know, about queer, LGBTQ, and BIPOC. You know, this is big. You know, it's being moved right now just by this particular training, which I love. I'm like, I never, you know, would imagine this. And this is awesome because we're sharing our truth and what's really happening. And the movement is real, you know, with the LGBTQ and the BIPOC movement of us speaking up, nothing for us without us, right? With us bringing our communities in. I've never seen it being moved this way, you know, where we can truly speak out. You know, I'm going on 22 years clean, you know, NA and AA was started in church basements, you know, and now we're here and we can come and really speak our truth and be at the table to say what's happening, you know, so that multiple pathways can happen. You know, and I think that's just the real piece, you know, being able to show up, speak your truth, being able to be okay with being vulnerable, being able to say, to cry and talk. Dr. Nacio talked about, you know, feeling from the heart, you know, feeling from the body, and how people, you know, connect more in that way when you look them straight in the eye. So I see it being moved in that way. And I want to say the holistic approach, because it's not just being moved by us, it's being moved by family members, you know, connecting in that way. The community connecting is moving in that way. Also have a transgender story and working, you know, in housing with, you know, connecting to make sure that they're heard and that everything that everyone gets in the world, we're able to give to anyone, not because of your, you know, your gender or anything. So with the housing movement, I can remember early on, it was like, okay, well, if you've had surgery, then, you know, you're going to have to go into the male house or the female house. Now it's totally different. You know, whatever you choose to be, that is where you can interview. That is how you can show up. That is how you get accepted, right? So I'm just seeing it move in so many levels when it comes to that. And the important thing is that we keep showing up. We advocate, you know, we organize. We can't stop doing that, because that's what's making this thing happen. You know, even with things that are happening in the world today, we have to be at the table. Nothing for us without us, really. So I see it moving in that way. I'm excited. I truly see it moving, and I'm excited about it. There are barriers, but I think, you know, as long as we keep advocating and organizing, I see it getting better.
Thank you, Ms. Jones. I appreciate that. And last but not least, Umberto, same question. When has the needle been moved forward? In other words, when have you seen increased engagement and retention among BIPOC LGBTQ clients as a result of your efforts?
Thanks, Jay. I've noticed when people have become more engaged is when you make available opportunities for them to become empowered and involved in whatever it is that I have been working on, most recently just clinical research, but also as a nonprofit leader, I've noticed people have become more engaged when you reach out to them authentically and they, I think, understand people respond to authentic leadership. So that's seen in increased volunteer engagement, being an all-volunteer organization at Latino Link. I've noticed more people are open to volunteering when you are present in the community and you make an effort, make intentional efforts to reach them and show them that you value their skills and whatever it is that they're offering. So I've also noticed that in clinical research, people have responded well to messaging that is culturally relevant and responsive to the Latinx LGBTQ BIPOC population here in Atlanta through direct marketing. I mean, you can call it marketing or just efforts online, social media to engage folks. I've noticed that it is also effective way to get more buy-in, and I've noticed that in my short period of time here at Emory, people have been more receptive over time to just hear you out and learn a little more about what we do here. So it is a long time that it takes to cultivate those relationships with community, but you have to remain steadfast and committed to growing that relationship if you're going to have success, like I've noticed, just baby steps.
Thank you, Umberto. I appreciate that. And we are getting into the question and answer portion of today's presentation, in which myself and Priscilla will facilitate. I love reading the script. It's just but before we get into the question and answer portion, I do want to highlight a comment in the chat box from Carmen Gray, and also want to reiterate that language is very important to the PTTCs and the ATTCs. Also, language is always evolving, and we're always unlearning and relearning how to communicate and engage communities. I'm just going to read our comment. I think is very important. And she mentions that transgender is an adjective, not a noun. So saying transgenders can sound offensive to a community, but saying transgender people, persons, or folks is a way to be more inclusive and a bit more accurate in the adjective of transgender. And Carmen, I appreciate you bringing that up, and I appreciate you informing us in ways we should always be informed in this community. So thank you for that. And with that, we are going to go to the question and answer portion, and I'm going to start with some of the questions in the chat box, in the question and answer chat box. If you have some, please put them in. I'm going to try to read them off as best as I can, and open it up to the panel in no order to just unmute themselves and answer those questions. So first question comes from Mohammed, and that is going along with, and I apologize, I'm getting very close to the screen. I feel like my glasses are failing me today. Going along with the conversation about maintaining good communication, an important part about creating a good relationship with different communities is taking in their critiques and feedback. How can we utilize critiques and feedback in an effective way without becoming defensive about it? So I'll open that question up to the panelists to answer. If I have to repeat it, please let me know. I don't mind.
First, can we get clarification on the word critic or critique? Is it critic like somebody who critiques, or the verb critique?
I took it as critiques, but if Mohammed wants to clarify if that's what they actually meant, a critic or a critique, but I would answer it as a critique. Mohammed has put in criticisms. So as we place, so I'll repeat the question, rephrase. Going along with the conversation about making good communication, an important part of creating a good relationship with different communities is taking their criticisms and feedbacks. How can we utilize their criticisms and feedbacks in an effective way without becoming defensive about it?
I can start. I believe personally that criticism and feedback is your opportunity to learn. So first, getting offensive about someone bringing how they felt from you or what you brought to the table is only for your benefit. The criticism and feedback is for you to go forward so that you can be more impactful in engagement with the populations that you serve. I think Anna said it earlier, sometimes we don't know what our biases are. I made a faux pas a while ago with the word transgender. And so what do I do with that? I better take it in and going forward, because this is the population that I serve, part of the population, and going forward and being mindful of how it can affect people, how it can affect my engagement with people. So first of all, the feedback and criticism is for your benefit. Use it as a tool.
I think too, also, if you're in the moment, like in the moment, somebody is coming at you, the best thing to do is just listen. Don't try to fight back. Don't try to respond. As soon as you're by yourself, loop in your supervisor or a mentor to process what happened. They will support you and help you to get to a place where it's not about you. Perhaps maybe they're just having a bad day, whatever the case may be. But above all else, do not engage, because they, like I say, they may just be having a bad day. And if you engage and you make that choice to respond back, you may be severing years of work of trying to build that relationship with that community. And they could be a key community stakeholder that you're, and it has happened. Elders in the community have come at me. And so you just got to nod your head. Thank you for your feedback. I will be sure and follow up with you after I talk about it with our director, whoever. That's really all you.
Yeah,
that's all I would suggest.
I agree with that. Yeah, for sure. I think acknowledgement is a big key part of that, because you want people to feel acknowledged. I mean, I know that if I'm on the other side, you have to empathize and put yourself in their shoes. I want to be acknowledged, so that's important. Yeah, and use that as a learning opportunity, like Dimitri said. That's all it is, and then consult with whomever and figure it out.
and I'll say, for me, I've experienced some of that. So, just being able to really sit back and feel in it and know what part did I play in it, how will I handle it the next time, to make it better. And then always questioning myself, I'm here for service, was that helpful to the person that was in front of me? Or was it about me, or was I really trying to help that person? So I have to really think that and, bring myself to the table every time to know my position, that I'm in a position of service. So I try not to take it personally, but of course it's hard sometimes when things are coming at you like that. So I agree with everybody, you sit back, you breathe in it, you get advice from your team so that you know how to show up the next time when that happens. So it really makes you stronger to go through something like that. Yeah. So and again, like our team said, it's a learning experience. Yeah.
Thank you all for that. We'll move on to the next question from Abrium. Question for the panel. In your work, do you approach clients with the awareness that being LGBTQIA+ BIPOC peoples are a part of a number of subcultures within the LGBTQIA+, in addition to their respective cultures, in being a BIPOC person alone? How do you all work with the intersections of LGBTQIA cultures? Example, challenges, barriers associated with being a member of respective LGBTQIA subcultures and Latinx or Black. And I can repeat any part of that question at any time, just let me know.
I'm gonna take a shot at that. So, because that's a very good question though. I'm like, okay. So I'm thinking like, as an African-American woman, that shows up as BIPOC, right? That it's important for, that person to know it. And I'm learning as in the field of recovery housing, because we have all kind of cultures, everyone that shows up differently. So we address it when it happens. Don't wait and let it linger on. And I'm just saying for the field that I work in that deals with recovery housing. So we've learned to not let it linger on when something pops up and someone feels they're being treated unfairly, or someone is not respecting their culture or respecting their, what they've chose to show up, their person. We address it on the spot. We have a meeting and there's moderation. It's like, let's get this out. Let's really talk about it. What's going on? We don't let it fester now. Because when it festers, it turns into something that's even bigger, when you just could have expressed, this is the way I want to, this is my pronoun, this is who I am, right? Or, maybe something needs to be brought to the table, even bringing things like, hey, let's do a PowerPoint on this. So we go a little deeper, because some people don't know. So they're approaching because they don't know. So we can't get upset because they don't know. Yeah, right? We have to teach them. So we've gotten even deeper where we do chapter meetings, and it's like, we're going to be politically correct on things, want to be culturally correct, so that you understand it and that everyone is welcome and everyone is respected. And that is like real new to us, right? Because we weren't doing that. It was like, you should just know, or because you're in recovery, you're in recovery. No, but it's so many more things because you're in recovery. You're more than just a person in recovery. And it's, again, recovery capital hits a major point with that. So we nip it as soon as it happens, and we address it and try to make it a learning experience.
Thank you, Ms. Jones. I appreciate that. Anyone else have anything to add before I move to the next question? Great. I'm going to move to a question. Humberto?
Yeah, I just wanted to add to that and say that you must be willing to embrace the person's full identity. That's the whole point of intersectionality, is you see the person for who they are, how they show up. You just have to embrace and celebrate them rather than choose parts of their identity. But yeah, that's all I wanted to add.
Thank you, thank you. I'm going to move to a question from Maxine Henry. And if I mispronounce any more names this afternoon, I apologize. I'm trying hard. Typically, we see prevention and treatment efforts happening separate from each other, as though they are linear and mutually exclusive. What ideas about how we can combine efforts to support individuals and their families to be resourced for the cyclical nature of these issues? Cyclical, I haven't heard that word in a long time. Thanks. And I am opening it up to the panel for ideas. So I guess the question is, what ideas for prevention and treatment to combine efforts and work together to address these issues versus working in silos? I hope that summarizes the question for Maxine.
I'm thinking, go take it away, Alberto.
No, I wasn't even sure if I saw that question in the Q&A, but I think I understand it. It's like, how do we combine efforts to address all these issues and not work in silos? I think just recognizing how interconnected our work is the first big step, and then being open to collaborating with others to address those core issues, or just address the issues that we're all working on in a collaborative manner is a first step toward that mission to ultimately, get people to a better place. And I think that's how I see that. I mean, it's simplistic, but I think there's a lot of work there that happens working alongside others who are in this type of work. You just keep that in mind, and hope that helps.
I had just a thought around that. I come mostly from the prevention side of the work. As it relates specifically to drug and alcohol use, one of the things that I've had conversations with around particularly Native youth, 13 to 17-year-old American Indian, Alaska Native, Indigenous identified youth. Again, this is on the prevention side, but it's to actually talk about what alcohol and drug treatment is and what it looks like and what are the different options out there as a form of prevention. Because I think a lot of community members might not know what that entails or what is even out there and available. And that, if you don't know, then you may not make the choice later in life to access that. So just basic education across the silos, if you will, but talking about treatment in a way that's non-stigmatizing.
I can share on that a little bit, because really with me and then in the housing section, of, and I can say prevention, we're connecting in that way, because in my area, with prevention, and I'm going to say because of the opioid epidemic that's happening in our area, it seems like they're having to connect. There's no way that they cannot. They're coming together with grants to get more creative and connecting with the seniors, the youth, just people in the communities and different, because it's like, you can be a pill popper and, you're not considered, but you're doing it differently and you're in another section. So we have been connecting in that way. And it's like Dr. Nacio said, it's like reaching out, and Roberto said it too, it's like reaching out and connecting in that way, because we want to connect. So I think the easiest thing on that is just reaching out. I've been able, our prevention, they wanted to connect more with the recovery community to better help the youth. So we were the ones that were able to go in and really share our story in a positive way, but saying it in a way that's like, hey, this is not something you want to go through. And we were the ones who, like, for seniors who are in our area who haven't even, who don't even consider it an addiction because they're popping pills, right? So connections are happening in that way, and they're happening now. So it's just reaching out. If you want to connect, honestly, it's not hard. It's a bunch of agencies in your area, and all you have to do is call and say, hey, I'm with prevention, you're with behavior. This is the topic that we need to connect on. Let's do such and such and make it happen. Yeah, and then remember, and this is Recovery Month is in the whole month of September is Recovery Month, and everybody is connecting in that way. So just giving you a little nudge at that. If you want to connect in that way, do some events together for September. The whole month is Recovery Month. And it's prevention, it's mental health, it's everything combined into one. Thank you.
If I could chime in, thank you, Ms. Anna. I think that was great. And I'm going to be transparent about this part. I work in a large organization. And so right across the hallway from me was a department called Community Health. I only thought that they only served patients that left the hospital to connect them to doctor's appointments for transportation, and et cetera, and a whole other list of services. I didn't know I could use their services. They're right across the hallway from me. I'm stressing out of how can I get persons that I have set up to appointments, that they have these barriers that is hard to meet, like transportation, phone services, access to different parts of their own health that they need, like different doctor's appointments, excuse me. And so I had to be told that I can use them. So a lot of times, know different parts of your organization, know what's surrounding you, and then it's easier to utilize them and see what you can use and what's not for you to use. So just be mindful of what's in your organization, and that'll be a great way to start.
Thank you. I am going to go ahead and ask one more question and then open the floor for some closing remarks from each other panelists in respect to time. And I apologize if your question was not answered today, but I believe that you have an option to email and we can try to get that question answered. So the last question from Ode. What advice can you give to us working organizations which are not representative of people we serve? Most of our providers are white and old. How can we point out their implicit bias in ways that are constructive to them? So I'm gonna get that like a 90-second response, if that's even possible.
I didn't understand the question, but I'm thinking if you to point someone's bias out, they have to feel that they have that bias. But I mean, for me, I would just bluntly say it. Sounds like you just mentioned a bias. Is that a bias of yours, or is that something you? Because sometimes people don't know that they have a bias. So for me, I would just say it. I feel like that's a bias. What do you think about that? Do you think that's a bias? Yeah, or give them literature on it. I mean, it depends on the person, and how they're going to take it. Are they going to take it offensive? Depends on which bias they have. So I think it's a lot of things rolled up into that one for me. But I'm more the person who would like to just say it. Come right out and say it. Yeah.
Likewise, Ms. Jones. Appreciate that. So I'm going to open the floor up for our panelists. I'm going to start with Dr. Nacio for closing remarks. It'll be about 45 seconds to a minute to close this out, and we'll go down the road.
Great, thank you so much. Well, it's been really fun to be here and to work in community with my colleagues today. If you are interested in learning more, talking more about American Indian, Alaska Native, LGBTQ two-spirit issues, please do reach out to myself or Cindy Sago, who's also on this call right now. We are both affiliated with the National American Indian, Alaska Native PTTC. And know that I'm sending good thoughts your way live from Tucson, that you have a blessed rest of your afternoon. Thank you.
Thank you, Dr. Nacio. Humberto, your best closing in 45 seconds.
Okay. So first, thanks for having me. I've been very fortunate to be part of this conversation. And I want to give a shout out to Dolca Michelle for inviting me, and for all of you for the work that you do. And I think it's important that we do bring in voices from underrepresented communities. And yeah, thanks for organizing this, and hopefully there will be more down the road.
Thank you. Dimitri?
Okay, I'll go. All right, so it's been an honor. This is our third session. It just seems to get better and better. Just an honor and a privilege to be on the panel with you great presenters. I learned so much. And I do want to say, if I guess I have to give a shout out to Oxford House. So our website is www.oxfordhouse.org. You know, we're evidence-based for people in recovery. And also something for the who's ever on, what's coming up is Mobilize Recovery. And I would, you know, Google Mobilize Recovery. That's dealing with everything and all that's involved with recovery, prevention, harm reduction, reentry, behavior, mental health, all of those awesome things, right? And they're having a big conference for September Recovery Month, and it's going to be virtual, but it's really powerful, and it's about organizing and, you know, connecting and advocating and connecting all of us together. So I would get involved with Mobilize Recovery. It's a national organization, so it's worldwide. There are team leaders in each state. Thank you.
And Dimitri, you want to close us out?
Yes, I just want to thank everybody that's on this panel and everybody that has invited me to such a great discussion here today. And I just want to close this moving the needle. Moving the needle means being engaged, meaning that you have to continue to take education in on the population that you serve. And while you're doing that, be open to the fact that we cannot do this alone. All the weight is not barrier on that one professional. So as a team effort, as a collective effort, we are moving the needle together as a community to combat the issues that face the LGBTQ community and BIPOC. Thank you.
I'm going to hand it over to Priscilla.
Thank you so much. This was incredible. Thank you so much, Jay, for leading this conversation so beautifully and making us feel so comfortable to share our experiences. Thank you for each panelist for sharing your knowledge with us. We all learned so much with you and with the participants as well. Thank you so much for joining us today. Our panelists, they were kind enough to share their contact information. So if there is any question that we could not answer today during the live event, please feel free to contact them directly. And here you will have also the contact information for each of our TTCs, the Central East ATTC, Central East PTTC, Dr. Ignacio and Cindy's PTTC, and our Hispanic and Latino PTTC. We share the link for our evaluation survey. Please reply to this quick survey. Your opinion is so important for us and is very helpful for the work that we do. And thank you again for the participants, for the panelists, for the moderator. We appreciate you all. We wish you a lovely day. Thank you. Gracias. Obrigada.